doctors. Hello, good evening, doctors. Hi, thank you for joining. Today we are here to discuss about a new Green Top guideline that has been started in October 2024. That is care of late intrauterine fetal death and stillbirth. Yes, this is a new Green Top guideline that is from RCOG guideline. Okay. So yes, let me introduce you. I'm Dr. Maimuna Tabassum and I'm going to take this class now. Yes, can you see the screen? Okay. So yes. So what is let's see this. This is published in 28th of October, that is 2024. Yes, this is the latest guideline. So what are the differences that have been given in this Green Top guideline? That is regarding the treatment or regarding the induction of labor. If you are planning for a vaginal birth, what dose of misoprostol and how much frequently you are going to give misoprostol has been discussed in this guideline. So that is the new thing that has been given up in this guideline. So let's discuss what is it. I have added some of the slides that are relatable to the Indian scenario also, like incidents and what are the things that we are going to do, and about some postmortem examinations related to India. The causes and factors are also have been added with respect to that of the GTG guideline also. Okay, my slides will be crisp. There is no so much of crap in it. Only 1 or 2 lines will be there, so that after your class you can remember at least 10 points regarding this topic, right? Okay, so first coming to the definition. What is stillbirth? Stillbirth is legally defined as a baby delivered with no signs of life, okay, with no signs of life, known to have died after 24 plus 0 completed weeks of gestation. So, what is late IUFD? What is fetal death? Refers to the babies with no signs of life in utero. Okay, so you have already known that the baby is died. Okay, in the uterus only you know that the baby has no signs of life. That is one thing. Okay, but coming to the stillbirth, what happens is, okay, coming to the stillbirth, what happens is there are no signs of life after delivery or before the delivery only, like during the process of labor. If the death occurs, that is known as stillbirth. Here you have to pay attention, that is after 24 completed weeks. Previously it is like 28. 3 to 4 years back it is like 28 weeks completed pregnancy, but now they're given as 24 weeks completed pregnancy. Okay, that is known as stillbirth and late intrauterine fetal death. You can see some of the other things. Yes, this is a old definition that has been given for India, that is 28 completed. Now I have changed it to 24. Okay, now coming to the what is neonatal death. Death of a baby within the first 28 days of life. After the baby is born, if there is a death, that is known as a neonatal death. In this, you have again early neonatal death and late neonatal death. Early is less than 7 days and late is from 7 to 28 days. Okay. So what is perinatal mortality? Perinatal, it means around delivery. Perinatal means around delivery. So this includes stillbirth, that is already died, and which includes the early neonatal deaths. Okay, stillbirth and early neonatal death contains perinatal mortality. Okay, so these are some definitions which you might encounter during Viva or during a practical session also. Some of the examiners are fond of asking such definitions. Okay, so that's why you need to remember. So what is stillbirth rate? That is the number of stillbirths per 1,000 total births. That is not live births. This is total birth. Okay, per 1,000 total births, you can calculate the stillbirth rate. Why we are going to discuss this stillbirth? Why this is so much important? Like previously in the previous class, we have thought of about discussing sepsis in pregnancy, and we have thought why this is important, because it is causing so much of maternal morbidity and mortality. Likewise, why we are going to discuss stillbirth? Everything has a reason. So see, every day 7,177 stillborn babies are there. So every day all over the world 7,000 babies are dying. and India contributes it to around 22%. India contributes to around 22%. These are Indian lines or Indian figures. That is 1622 babies. 1622 babies die every day. This is a huge, huge number. 1622 babies die every day. So we need to pay caution, or we need to pay attention why these deaths are occurring. Is it due to mismonitoring, or is it due to some other cause, or is it due to undiagnosed any underlying conditions? Okay, so that is the reason why we are going to discuss this. And the stillbirth rate is 23. That is 23 per thousand total births. The stillbirth rate is 23 per thousand stillbirth total births. Okay, that is the reason we are going to discuss what are the risk factors about late intrauterine fetal death and stillbirth also. Okay, so what are the risk factors for late intrauterine fetal death? You can have some non-modifiable risk factors, that is the risk factors which you cannot modify, and some of the risk factors that are potentially modifiable. It means if you pay attention to those risk factors, you can modify them. Let us see what are the potentially modified risk factors. The first one is pre-existing hypertension. If you have a hypertension, a well-controlled hypertension can lead to a healthy baby and a healthy mother. Then comes to the obesity or overweight. You can have weight exercises, weight reducing exercises, good lifestyle, such things, and smoking more than 10 cigarettes per day. See, this is a very major risk factor which you can avoid very easily. That is smoking more than 10 cigarettes per day, alcohol, illicit drug use, going to sleep supine, living in the areas of most deprivation. Okay, such things can be modified easily, and you can reduce a large number of stillbirths occurring, or a large number of late intrauterine fetal deaths occurring, right? Next comes the non-modifiable, which you cannot modify. Maternal age above 35 or below 20. That is extremes of maternal age also can be there. Black Asian backgrounds are having high risk of late intrauterine fetal death, previous stillbirths, and then advanced gestational age, that is more than 41 weeks. So my thesis is actually about this only, like what is the observational study on the maternal and fetal observations, that is post-dated pregnancies. In this, I can see that due to meconium strained liquor, most of the babies are having stillbirth or IUFDs also. That is the reason this is important. Actually, this is my thesis topic. So now we are going to have a new course, that is we are helping you to write the thesis also. So thesis writing guidance is also there. If you are interested, you can check out the app as well, and you can contact me, right? Okay. Yes. So advanced gestational age is also one of the risk factor for late intrauterine fetal death. Then coming to the fetal growth restriction, or small for gestational age less than 10th centile. And if you are having any reduced fetal movements, if the patient is complaining reduced fetal movement, don't ignore. You need to have a clear cut thing why she is having a reduced fetal movement. And in cases of any malaria or thyroid disease, or any cases of thrombolytic disorders also are a risk factor for late intrauterine fetal death. Okay, so these are the risk factors. Now coming to the diagnosis, how you are going to diagnose the intrauterine fetal death. So I don't think I'm going too fast. If you think that I'm going fast, you can please stop me, because what's my point of view is you people don't have so much of time to listen to so much of scrap, and I cannot lag you, because if I am a student like you, I don't want to listen to a very lengthy lecture having so much of discussion and so much of lag in it. I cannot bear it as a student. So from your point of view, I'm just running fast so that you can just imbibe some of the important points. Don't worry, I'll share the PPT also with you. But if you think I'm going too fast, you can just text me, or you can just leave a feedback to the class in the YouTube also, so that I can change my tone, or I can just slow down also. Okay? Yeah, thank you. So coming to the diagnosis of intrauterine fetal death, how you are going to diagnose? What are the symptoms of that the patient might say, and you can just doubt of intrauterine fetal death, the most first and foremost is the absence of fetal movements. This is the first and foremost. This is very important. Absent fetal movements, and any history of trauma, any history of domestic abuse, any history of physical violence, any bleeding, history of diabetes, hypertension, and any of the risk factors, you might have a frequent danger of having this IUFD. Okay, so what are the signs that you are going to see? So the signs are, on the palpation you can feel the fundal height is less. This is possible only if the intrauterine death has occurred long back. Okay, this is possible only if the intrauterine death has occurred long back, that it is more. And no fetal movements you can observe, and in the auscultation also no fetal heart, and on the ultrasound you can see no fetal heart and no fetal movements. Okay, what is the most important is ultrasound is mandatory, and it is a diagnosis of choice. It is used to confirm the intrauterine fetal death. If you see intrauterine fetal death, a second opinion is must. Okay, this is to be confirmed by two doctors. Intrauterine fetal death is to be confirmed by two doctors. This is very important. You cannot simply say yes, your baby have died, and then if the baby is then you will be sued for it. Be different doctors have to confirm it. So on mere auscultation, only after auscultation you cannot confirm IUFD, or with cardiotocography also you should not diagnose intrauterine fetal death. So auscultation and cardiotocography should not be used to diagnose the late intrauterine fetal death. Okay, so I have a question for you. If the fetal movements are felt after the scan, you have told her, she told that fetal movements are absent, or on incidental scan finding you have seen that the cardiac activity is not there, and you have told that intrauterine fetal death has occurred. Then if the patient told you, no, I'm feeling fetal movements now, then what to do? Then what to do? Get ready for passive fetal movements. Okay, there might be some passive fetal movements due to the fluid around it. Okay, so passive fetal movements could be there. What is the next step to do? She told, yes, I'm feeling fetal movements now. Then repeat scan. Scan should be repeated, and it should be done by an expert radiologist now. Okay, scan should be repeated. So what are the ultrasound features where you can see, or where you can find out that this is an IUFD or intrauterine fetal death? So the first and foremost thing is the absence of fetal cardiac activity. Okay, and what are the other features? The other features that might be seen are known as secondary features. So what are the other features you can see are collapse of the fetal skull with overlapping bones. This is important. Collapse of the fetal skull with overlapping bones. Then hydrops or maceration. Maceration is nothing but a softening of the skull, softening of the body, which results in unrecognizable fetal mass. So whenever there is a IUD, like 3 days back, 4 days back, 5 days back, 1 week, it means that the baby has macerated. The baby has macerated. It becomes softened. It becomes liquefied. Mummification. Okay, and then intrafetal gas also could be there in the heart or blood vessels and joints. This is also another feature that is associated with late IUFD. Here you can see, yes, which can I use? Okay, here you can see there is a overlapping bones. See, otherwise it would be like this, no? Otherwise it would be something like this. The bones will be like in a single shape, but here what happened? They are overlapping. That is overriding of the bones. Okay, so this is one of the feature where the IUFD can be confirmed along with the fetal heart. Okay, so why you are concerned about IUFD? Okay, fine, the baby has died. It's very sad. But why you are concerned regarding the mother? Because she might experience a dreadful, dangerous complication if you have not acted accordingly. That is DIC. DIC is a very dangerous complication that is disseminated intravascular coagulation. This is a very dangerous and dreadful complication that can occur if the IUFD or intrauterine fetus is left intact after death of the baby. And the other complications are sepsis, acute renal failure, and sometimes it might lead to maternal mortality also due to sepsis. So you should be cautious of the intrauterine fetal death. Okay, not only it is a sad for the baby, but it is also sad for the mother. So you should be cautious whenever a patient comes with an intrauterine fetal death. So how you are going to counsel? So first you have to break the bad news. So breaking bad news. So if we are thinking of this, breaking bad news, I'm just getting out of the subject now, but this is important. Breaking bad news, it is very important in OSCE. So now they have given you a new format for OSCE, that is a new format of PG exams, that is OSCE, Objective Structural Clinical Examination, in which you will be assessed with your communication skills and patient safety and some other domains. If you have not seen the OSCE video about us, you can see in the YouTube. I will be posting the link also down below. So this is a breaking bad news is a very, very important concept in OSCE. So this shows how empathetic you are and how pitiful you are for the patient situation, and how you are changing your tone, and how you are convincing your patient, how you are counseling your patient, and how you are telling the news that the baby has died. You cannot just say, yes, are you Jennifer? Okay, your baby has no heartbeat, and we declare that the baby has died inside. Can you say that? No, you cannot. You have to think of any disclosures like if she is under control or if she is stable or not, then only you can say that the bad news can be broke. So you need to ask if anyone else is with her or not, and then you need to break the bad news. And no jargons. What is jargon? Jargon is nothing but a medical terminology. Okay, you cannot say, okay, your baby had undergone intrauterine fetal death, and now we need to give the induction of labor, and we need to terminate the baby, or we need to terminate the pregnancy. If we do not terminate the pregnancy, you might land into disseminated intravascular coagulation. Does any of the pregnant women will understand what you have said? She will be stuck at the first word only, that is, the baby died. Okay, she cannot hear the all the other things what you have said, what blah blah blah, you have mumbled everything that you know. It is not important. The patient wants to know only some things that is necessary for her. So just assure her if she is alone, if she wants anybody to be there, and give some alerts. Breaking bad news is itself a chapter. We need to give some alerts. First, create an environment where you can tell her freely, and then give one warning shot, then again then give second warning shot, then you break the bad news. Okay, something like that it will be there, and you should not use any jargons, and you should be with utmost empathy and care. Utmost empathy and care. Okay, so that is the counseling thing which you have to going to offer. Okay, then you will be discussing about the intrauterine fetal death, how this has occurred. The first thing they will ask is why the baby has died, why this has occurred, why this happened to me. So such questions are normal in such kinds of scenarios. So we need to be ready to face all those, and then we need to be with empathy and with care. So after that, we will be discussing the mode of delivery. So what kind of delivery can be there? Most of the times they will be delivered vaginally, but if she is well, if she is physically well, if she is not having any risk factors and no signs of any disseminated intravascular coagulation or thromboprophylaxis, you can wait till 48 hours. Okay, till 48 hours, there is no hurry to deliver her immediately. We can wait till 48 hours, and you can look for the signs of any disseminated intravascular coagulation, any pyrexia, any sepsis. So such things you can monitor. And if any risk factors are present, like any preeclampsia, GDM, or any thrombolytic disorders, immediate delivery is to be planned. There is no fun of waiting there. So immediate delivery has to be planned. There is a 10% chance of maternal disseminated intravascular coagulation within 4 weeks from the date of fetal death, and an increasing chance thereafter. See, the things which I have marked in red and highlighted, these are the things directly from the guideline. These are the lines directly from the guideline. And this is very, very, very important. The timelines are very important. If you have confirmed her today that the baby has died in utero, and she wants to see for normal delivery, I don't want any induction, I'll just see. If the delivery has occurred within 4 weeks, that is actually very good. But if after the fetal death, if she has carried her baby for at least a period of 4 weeks, there is a 10% chance of having maternal disseminated intravascular coagulation, which is a very dreadful combination, and we cannot afford this. So we need to tell her within 4 weeks there might be increase of disseminated intravascular coagulation, where you should be cautious of. And we need to explain her what might be the risk of having this expected management without any induction of labor. If she is not going to have any induction of labor, this might land her into trouble after 4 weeks. Okay. So if you are going for an induction of labor, there is a 90% chance that she might deliver vaginally within 24 hours. So the vaginal birth will occur in about 90% of the women within 24 hours. Okay. So how you are going to induce the labor? Induce the labor can be done in two forms, that is, if it is an unscarred uterus or if it is a scarred uterus. If you can say this is an unscarred uterus, so in the unscarred uterus, you can use mifepristone and you can lavishly use misoprostol. So what is the first line? The first line is the mifepristone and the prostaglandin. In the prostaglandins, misoprostol is better than that of the prostaglandin E2. So you are using this misoprostol. So this slide is very, very, very important. This slide is very important because this is the changed version of Green Top Guideline or RCOG. This is the changed version where you have been given about the unscarred uterus. Okay. So what you are going to do? You can use from 24 to 28 weeks of gestation, you can use misoprostol easily in an unscarred uterus. Now in the coming slides, we will be discussing about the scarred uterus, where also you can use misoprostol, but in a very less doses. Okay. But in cautiously you have to use. So coming to the doses. So you can just listen this. I'll send you the PPT later in the app so that you can just go through all the slides, and this slide is very, very important. From 24 to 24 plus 6 weeks of gestation, you can give 400 micrograms of misoprostol every 3 hours. So every 3 hours, 400 micrograms of misoprostol, and from 25 to 27 plus 6 weeks of gestation, 200 micrograms misoprostol every 4 hours. And from 28 weeks of gestation, you can give 25 to 50 micrograms vaginal misoprostol every 4 hours, or 50 to 100 micrograms oral misoprostol every 2 hours. Okay. And you can just counsel her. The vaginal misoprostol and the oral misoprostol will be having the same efficacy, but oral will be having more side effects than that of the vaginal. So that thing we can just counsel her, right? So yes, take a moment to look this slide and just have a note. So this is easy actually, 24 to 24 plus 6. So for 1 week, you will be giving 400. Later for 2 weeks or 3 weeks, you will be half the dose. You will be giving half the dose, that is 200 micrograms every 4 hours, right? So this is about unscarred labor. Unscarred uterus. Okay. Then what about induction of labor in the scarred uterus? See, this is very important. Previously, they used to say misoprostol cannot be given, but now they are saying if you have any previous cesarean birth or any transmural uterine scar like that of any myomectomy scar from 13 to 26 weeks of gestation, this is important. This is very controversial actually, but that's why I have kept the exact box which was given in the guideline. So what they are saying, misoprostol can be used in the post-cesarean. So between 13 to 27 plus 6 weeks of gestation, you can use it. Okay. So how you are going to use it? So these are the things: 24 to 24 plus 6, same 400, and then 25 to 27 plus 6, same 200. That is same. And they have licensed it like 13 plus 6 to 27 plus 6. Sorry, 13 to 27 plus 6 you are going to use, but there is no evidence to use misoprostol after 27 plus 6 weeks in a scarred uterus. If a patient coming with post cesarean and she is 32 weeks of gestation with IUFD, you cannot use misoprostol. You cannot use misoprostol, but here in this scenario, you can use misoprostol here. Okay. In an unscarred uterus, you can use misoprostol after 28 weeks also, but in a scarred uterus, you cannot use misoprostol after 28 weeks of gestation. Right? So, the first thing you can do is non-mechanical things, that is balloon dilatation or Foley's catheterization. You can do it. Oxytocin augmentation also should be done, can be done, but with caution and with the consultation of the obstetrician only. Okay. So, in the scarred uterus, if you are going to have an induction of labor, there is a 2 to 3 times of risk of rupture in cases of IUFD. In cases of intrauterine fetal death, there is a 2 to 3 times of increase in the risk of uterine rupture, right? So that is the reason we need to be very cautious regarding the things, right? So what is the most common early sign of scar dehiscence here? So the most common early sign of scar dehiscence, this is a question for you. Usually, normally, in cases of previous cesarean section, if you're trying for a TOLAC, then what are you looking for? In cases of early scar dehiscence, it would be fetal heart. Okay. So now what we are discussing? Intrauterine fetal death. See, no point of fetal heart here. So how are you going to identify the early sign, or how are you going to identify the scar dehiscence? Yes. So that is the main reason you cannot have a very reliable factor to identify the scar dehiscence. That is the reason why induction of labor in post cesarean is very risky. Okay. Okay. So you can have a cervical ripening with transcervical Foley catheter in cases of if there is a unfavorable cervix. Okay. So now coming to the investigations. What are the investigations that you are going to perform? So the patient might ask, yes, why this has occurred to me, or she might ask, okay, so here investigations comprises of two things. You need to investigate the mother, you need to investigate the baby. So what are the investigations for the mother? The first thing would be hematology, and CRP and bile salts will be there. Maternal coagulation, to know if she is landing into disseminated intravascular coagulation or any thrombotic disorders, and CLIHOR test to look for any Rh negative incompatibility. Then maternal bacteriology, like any sepsis or any UTI that might cause this, and any infections also like HIV, HSV might cause some intrauterine death sometimes. So if she is having any GDM or any risk of gestation, any risk factors for gestational diabetes, then also you need to have this blood glucose, HbA1c, thyroid. So these are all the things that might cause intrauterine death, sudden intrauterine death. Here you can see this anti-Ro, SLE antibodies. Okay, that is the reason why you are going to have all these tests, and parental blood for karyotype, toxicology, placental and fetal microbiology, and then you are going for a cytogenetic testing. Okay, cytogenetic testing you can be doing with karyotyping, or you can do it microarray. Okay, or you can do it microarray. So these are the cytogenetic testing, and finally the most important thing is the postmortem examination. We will be discussing in detail. Okay. So these are the investigations that you are going to look for, and you are continuously monitoring the patient if she is landing into any sepsis or disseminated intravascular coagulation. Then after delivery, what you are going to do? The first thing is keep the patient in isolation. Don't hurry, or don't keep her in a ward where there are full of babies, or if anyone is taking care of. So place her in an isolated room. Utmost care is needed, family support is needed, husband support is needed, and tell her what has happened, and make her calm. Okay, and you can give antibiotics only if needed. And if there is any form of lactation suppression, and if you want to stop the milk production, you can give the dopamine agonist, that is cabergoline and bromocriptine, in which cabergoline is more effective than that of bromocriptine, but this should be used with caution in cases of hypertension. So if the patient is hypertensive, it should be used cautiously. Okay, so what are the doses? Cabergoline can be given as a single dose, that is 1 mg, and bromocriptine you can give 2.5 mg twice a day for 14 days. And what else you can give? Thromboprophylaxis, because she might be having a higher risk, that is 6 times higher risk of having thrombosis or thrombolytic emergencies in cases of IUFD. That is the reason you should give the thromboprophylaxis, that is low molecular weight heparin. So this is the postpartum care. So overall, what is the cause of late IUFD? After the delivery, the patient will ask, why this happened, doctor? Then you have what are the investigations you are going to perform. The first one is verbal autopsy. What is verbal autopsy? Detailed clinical history taking. So you might miss some history previously, but as now she came with IUFD, you have to ask each and everything in detail, from ethnicity and from what are her factors, what are her hobbies, what are her work environment, any physical abuse, any domestic violence, everything, each and everything should be done. That is known as verbal autopsy. Then coming to the clinical and laboratory tests are also to be done. And then comes the postmortem and placental histology. Okay, yes. So in the postmortem, yes, there might be some features where you can directly see, and you can say what time it was being death. Okay, the approximate time of death also you can say. Here in this picture, you can say this is like approximately 4 to 6 hours back the death has happened, because it exhibits hyperemia of the face. See, the face is very red. Hyperemia of the face is there, and some hemorrhages on the chest, which means 4 to 6 hours from the 4 to 6 hours from the death, right? Then the next picture shows desquamation. So peeling of the skin is there sometimes. Okay, that is not the approximate time of death is 8 to 10 hours. Here you can see the skin desquamation, approximately 25% of the body. Here you can see that is desquamation only, with skin discoloration is also there, 18 to 24 hours. Here you can see the macerated skin, slippage of the skin is there. Slippage of the skin, and approximately it is 36 hours. Okay, so these are the timings. That is not so much important because the pediatrics people will be examining the baby, and this is not so much important to remember, but you can just remember what is maceration and when can it occur. Okay, so mummification occurs more than 2 weeks. If it crosses more than 14 days, mummification will occur. Okay, here these are the external features where you can sense the time of birth. By this only I have said this time of birth. What is the macroscopic appearance? You can see 4 to 6 hours, you can see the skin slipping, and collapse of the skull will be there. Okay, softening and joints laxity also will be there. Okay, you have identified it, and you are going to counsel for the postmortem examination. Before that, you have got to know that the mother is Rh negative, she is AB negative. What to do now? So CLEHAR test should be undertaken immediately to detect if there is any large fetal-maternal hemorrhage that has caused this intrauterine fetal death. So if any fetal death has occurred in an Rh negative woman, immediately go for a CLEHAR test. Then determine the fetal blood group also. And if there is any need of anti-RHD immunoglobulin, give to the mother immediately. Okay. So these are the exact lines from the guideline. What they have given is, if there is a large fetal-maternal hemorrhage, dose of the RHD should be adjusted. So you are having this RHD immunoglobulin program, in which based on the fetal-maternal hemorrhage, the anti-D immunoglobulin dose also will be changed, and it should be given within 72 hours, but it will be beneficial up to 10 days also. If the mother is not well and if she is not willing to have the injection, you can give after like within 10 days also. It is beneficial, but it would be great if you give within 72 hours. And what else you are going to do? As I have said, this cytogenetic testing is to be done, where karyotyping, microarray analysis, and QFPCR also is important. Why you are going to do cytogenetic testing? Because it is an important element. And why this is 6% to 13% are having this cytogenetic anomaly. The babies are having this cytogenetic anomaly. So that is the reason why you are going to do this. Okay. Then, for this cytogenetic analysis, you will be connecting the placenta and the fetal cord. How you are going to collect the placenta and store it? Most important point is placenta cannot be stored in formalin. Placenta cannot be stored in the formalin before the biopsy is taken, because it will decrease the tissue, or it will not show a clear cut thing that can be given. That's why placenta should not be stored in the formalin. And how you can take the placental biopsy? Approximately 1 centimeter diameter should be taken from the fetal surface close to the cord insertion. Close to the cord insertion. Because if you, to avoid the maternal origin, only close to the cord insertion, you have to take the 1 centimeter diameter of the placental biopsy. Cord biopsy should be taken 0.5 centimeters in length, and this is more important. It's to be stored in the ringer lactate solution, not formalin. Not formalin, only ringer lactate solution. Right? Okay. Next. So you have done the postmortem examination, or a placental biopsy has been done. Then what can you do? Another new thing that has appeared is seeing, holding, naming, and mementos. They have a very mixed opinion. The scientists are having a very mixed opinion. Conflict is occurring regarding this concept. What this concept? What is this concept is the opportunity to spend time with the baby, to make memories with the baby, should be actively supported and offered. So the nurse or the nursing staff should encourage the mother to hold the baby, see the baby, name the baby, and if they want, they can offer photographs or any artifacts like nails, or hair, nail, some things like that can be offered to the mother as a memory of the baby. And then we should be discussing about the burial also, about the disposal of the baby. Like they want, some cultures will be having the burial, so according to their culture, according to their region, we can offer the burials or cremation of the baby also. So most of the people are having a mixed opinion with this concept, seeing, holding, naming, because some say yes, this might help the mother to get out of her grief very early, as she can see the baby. Like in our cultures, they will not show the baby to the mother, but in some cultures they said that, or in some regions the others are arguing that if you show the baby to the mother, she might have a sense of satisfaction, and she might have a sense of relief, and she might get early from the grief. But some others are saying that this might land her into more depression, and she might think of the baby repeatedly as she has seen her. Okay, this is a very mixed opinion. We can just omit it, or just remember that they have mentioned this sharing thing in the guideline. Okay. So this is all about the thing that we are going to do in the intrauterine fetal death. We need to monitor her. We need to do the postmortem examination. If they are not willing for we need to convince the parents regarding the postmortem examination. Why? Because if you have a full and complete detailed postmortem examination, most of the uh, causes of intrauterine fetal death can be known. But a bad thing that is happening is many of the parents are not agreeing for the postmortem examination complete. so that we need to see what are the benefits of this postmortem examination, and we should say regarding the subsequent pregnancies also, how does this affect and what are the treatment we can give to prevent subsequent intrauterine fetal death also can be done with this PM examination. Okay, the bad thing has happened. Now the patient went to the home. Again, she came with a pregnancy. Now she is so apprehensive that she doesn't leave you. In the OPD, she is asking you, no doctor, previously it has happened. Is there any chance of happening it again? And what precautions can I do? What can I do, doctor? I'll do whatever you say. So such things we can experience in our OPD. So this should be first regarded as a high risk pregnancy first. And the single most important factor is the previous IUFD. Whenever you are having the previous intrauterine fetal death, it is a very high risk factor, and 4 times there will be recurrence also. 4.8 fold there will be recurrent late IUFD. So this is actually very important risk factor. So what you are going to do? Every 3 to 4 weeks, like every month from 28 weeks, 26 to 28 weeks onwards, you are going to do fetal biometry, AFI, and umbilical artery Doppler every 3 to 4 weeks, right? To look for the well-being of the baby. Now coming to, you are giving aspirin 150 mg. This is very important. Aspirin 150 mg will be given to look for if there are any problems or any thrombolytic disorders, any platelet insufficiencies, such things, or platelet dysfunctions also can be reduced. So the most important IUFD factor that have been got into thing is placental dysfunction. So for this placental dysfunction monitoring, you are going to do Doppler, and for reducing any kind of placental dysfunction, you are giving aspirin. If she is a potential case of GDM, if she is a potential high risk factor for GDM, GDM screening is also to be done, and low molecular weight heparin may be considered because previously she might have any thromboprophylaxis. That's why low molecular weight heparin also can be considered. The most important thing when you are going to deliver her, as she already had an intrauterine fetal death, you are going to have an induction of labor at 39 weeks of gestation. Okay, induction of labor at 39 weeks of gestation. Okay, now coming to the summary of what is the preconceptional visit or initial prenatal visit in the following pregnancies. Detailed history is to be taken. What is the evaluation of prior stillbirth? If she had done any postmortem examination of the baby, she can tell the result or show the report. Recurrence risk, how much you can discuss and determine based on her risk factors. Okay, and then cessation of smoking, weight loss is to be told, genetic counseling is to be done. If you are having any screening, diabetes from previous screening is to be done to look for any and need for any normal weight heparin also you need to. Okay, this is about the summary of the pregnancy following stillbirth. So why we are going to do this much is, as we have told, over 7,000 babies are dying every day and around the world, and around 1,600 babies, 1,622 babies are dying every day in India. There is in stillbirth, so we have to take a action regarding stillbirth. Yes, the every newborn action plan, ENAP, to end preventable deaths has set a stillbirth target of 12 per thousand or less by 2030. Now we are at 22 or 23. They have reduced it to half. That is actually a very doable thing because of the modifiable risk factors we are seeing. So we can modify some of the risk factors, and they are planning to have a target of 12 by 2030. Okay, this is a new target. So that's all for today. This is a new green top guideline. I hope this might be your topic. So this is a new green top guideline which you need to review. Most of the topics, most of the things you know here, but I have told you in detail as you can cover both of the things. So the most important is induction of labor in an unscarred uterus and in a scarred uterus that has changed. Okay, and about the maceration or mummification, and about the postmortem examination also, how to hold, how to store, everything is important, and following subsequent pregnancy is also very important as this is considered a high risk pregnancy. Yes, thank you for your patient hearing, and just a minute of your time. to just share my app and Telegram channel where you can where you can follow, and you can have recent updates, articles, and recent classes in the recent advances, or any of the things. You can have this. Okay, so this is my Telegram channel where you can yes, see, this is my Telegram channel. Okay, you can just go through for recent updates or any of the announcements. So just let me take a minute to discuss about my app. So this is my app where you can go through my courses. So in the courses, I have given you 8 weeks course or a regular course of 2025, in which you will be discussing the question and answers, previous year questions, regular classes, everything will be discussed. So whenever you open the app here, this will be my organization code, and these are the free materials you can just access. So documents, videos, and tests will be there. In the documents, you can go through all these Gynec Gyana docs obsession. The photos will be there, and the videos. If video I'm discussing will be posted here. Okay, so these are all the things that we have discussed, and these are my Telegram channel, that is Educational Academy, and this is my number where you can text me anytime. Yes, this is my WhatsApp number, and this is the Instagram. We are having another Instagram that is active now. I'm not 28. Okay, you can join for further update also. So I would like to I'm happy to share with you that we have extended our expertise to MBBS students also. So we are discussing some MCQs for MBBS theory examinations. Their exam pattern have been changed, so we are helping them. So whoever are having any difficulty, or you want to share our app, it's very appreciable. These are my app links and the QR codes where you can happily share them. And here, this is the PG theory exams coaching, that is regular course for MS and DMB, and previous year question course also is there. Those who are going to join, you can just text me. Okay, so yes, that's all for today. Happy learning, and thank you for your hearing. Thank you.